Okay. Welcome to this the Regimen this is Public Health Grant Program. Today we are going to interview and telecast the success stories of public health in Sri Lanka. One of the eminent person who architects the public health policies and also a leader in the planning of health system in Sri Lanka, who has vast experience in the Ministry of Health and international organizations, and who is a public health specialist and a medical administrator. I think you know the Dr. Sarath Samarage. Welcome, sir, for this broadcasting series.
Thank you.
Sir.
Happy to be here.
Okay, sir. We are now going to discuss the success stories of Sri Lankan public health system. Especially today we are going to discuss focusing only on this NIHS, that's the key for success in Sri Lanka, that National Institute of Health Sciences, which is in Kalattara. So during the formative decades of Sri Lanka, in the public health system, the establishment and gradual expansion of this National Institute of Health Sciences marked a straight shift from that ad hoc field training towards structured, competency-based health workforce in Sri Lanka. So from your perspective as a senior health planner and a former Deputy Director General of Health Service for Planning, what institution design features of this NIHS enabled us to become a foundation pillar sustaining Sri Lankan preventive health system over all the time?
Yeah, Sri Lanka as a developing country achieved a great health status. If you go through the indicators, we enjoy very good health indicators compared to other similar countries, and that was brought about mainly by the public health system that evolved over time over the last 100 years. So NIHS in that development played a crucial role in shaping the public health in Sri Lanka. So if you take the design features, the most important feature I see is this integrated training of different categories of staff in one
place,
because they are working as teams in the field. But if you get a training working together, is the other feature is the field practice area. If I go back, it was when the Institute of Hygiene became the National Institute of Health Sciences. When that transition happened in 1979, Dr. P.A.D, he was the regional director for the WHO Southeast Asia region. He visited this place, and it's his brainchild. Taking over a field area and setting up this field. That is the most unique design I see, which many countries, many other global institutions don't have. And that is another area.
It's not the classroom teaching or
that's right.
practical experience.
So 52 square miles was taken over by the NIHS, carved out, and it mimicked another district so it was made like a regional director.
I think it's Nagoda and
yes, Berula and Kalattara MOH areas are taken with the preventive and curative services board under the same umbrella. That model was developed over the years. This thing is the multidisciplinary faculty that they have different areas of specialities merged there, and they provide the teaching there. And then the other design feature is the robust infrastructure. Over the years, it has developed like a huge campus with lecture rooms, conference facilities, and also residential facilities. So that's another unique design feature. And if you look at the structure of this thing, there's a director is equivalent to a regional director of health services in other country, other parts of the country. And then under him there are 3 deputy directors, one for the deputy director field services, deputy director curative care institution, deputy director for training. So under the deputy director training, all the training is developed there, and there's a field service. All contribute in the training, and that will develops a very good this thing. So those are some of the design features that I could recall.
Okay, sir. So this is a very good success, especially for the maternal and child health,
Yes.
and communicable disease control and community level prevention for several health issues. We had this public health midwives and public health inspectors are the key for them. So in your assessment, how did this institutionalization of standardized training at NIHS contribute to transforming this public health workforce from just a service card? Earlier there was just a service card to a system stabilizing forces, so capable of maintaining the continuity across the political, any changes, the political economic changes, they didn't change that.
Yeah, NIHS replaced the fragmented on-the-job learning to a structured curricula for basic training of public health midwives, public health inspectors, public health nurses, and the MOHs. So that structured curricula aligned all public health midwives, public inspectors to the same standards, reporting systems, preventive care, protocols. Then the institute also embedded the field practice. Then the supervision norms we are using, the students go to the field and they see how in practice, how public health is in practice, and community engagement methods. That's very important in public health, and that strengthened the frontline workers. And also the other feature is the continuous in-service. They, after the basic training, time to time they are called back for in-service training and update them.
Not only the public health staffs and also the supervision staffs also. I think definitely, I think they are the SPHIs and SPHMs also, and public health nursing sisters. This is the only place we have the public health nursing sister training and MOHS training. Still, I can remember my period in NIHS during MOH training. So it's very pleasant and things are there. So the following independence in 1948, I think Sri Lanka adopted a welfare-oriented health policy model. Later it's strengthened through the national health plans and sectoral reforms, particularly during 1970s and 80s. I think that's what the NIHS also formed. I think the primary care principles, especially with our alma mater declaration of in 1978. So embedded in the national policy. So in what ways is this policies NIHS operationalize these policy commitments? Usually we are very good in policies, but implementing we are very low. But how does NIHS operationalize these policy commitments in the training level and ensuring preventive health personnel were aligned with evolving national health strategies and global frameworks?
One of the important issues or factors that contributed to this converting the policy into practice is this two standardized curricula. Based on the policies, the teaching and learning on the curricula were designed to address the policies, especially say maternal and child health policies, environmental health policies were brought in. So the curricula were in line with those policies that is existing. And then the other factor is the structured field practice, and then also continuous professional development. So these are the three factors that.
So under this, so a lot of achievements we had. Things was a maternal and child health, communicable disease control. But is there any areas we are lacking still, even included in the curricula based on the policies, but we couldn't achieve any things?
Most of the areas we have achieved, and then various other initiatives were also started in time to time. That is another feature of the keeping in line with the changes happening in the environment and globally. So we had to adapt this thing to address the emerging needs of the country. So that
that's one thing. So one of the question is, we are more successful in certain areas of public health. there are certain areas there, say for example, occupation health and safety
Yes.
is not that much we achieved
Yes.
in country, I think.
Yeah, that's one area that needs to be further strengthened because the working population is important. So it's the leadership that the policies and then the nationally that those things, and in terms of training, they tried their best to address the needs of this thing. Even the visit all the factories and training, and they understand the need things. So there are certain gaps that need to be. One reason for that is the lack of trainers.
Trainers, maybe.
We need people specialized in those areas.
Definitely,
that is the gap, I think.
Sure.
In this thing,
because
we see especially the public health inspectors with those experiences, they become tutors. Very few people take up tutorial positions.
Yes.
Because they are better off in being in the field.
Being a PhD.
So that is a bottleneck in improving because they play a crucial role in the occupational and environmental health. So that's
I also think one of the area we need to in future.
Yes, very, very important area we need.
Okay, so that functioning for this NIHS, so the legal mandate and the regulatory frameworks. I think we have a lot of regulatory framework for, especially the 1898 public health ordinance is 97 public ordinance is there, and also recently I think the Food Act is there, and also the NATA Act in 2006. We have things for enforcing the things to be implemented in the field level. So how critical this NIHS has been equipping public health officers with the regulatory competencies necessary to translate these legislative instruments into effective community level actions, I think.
Yeah, in that sense, it is very important that you embed legal literacy in the core training. Although the NIHS doesn't have its own capacity, they depend on external resource personnel, lawyers coming and giving lectures, and it's part of the curriculum, and also the developing practical enforcement competencies. The students are sent to the field and see how these legal actions are they going. Checking the food establishments, going to a factory and inspecting and taking action, taking legal listening. Those the students themselves, through practice, they learn and see how things are done. So in addition to the classroom teaching on legal matters, they see that how it happens. So that's another. So, and also establishing uniform protocols and compliance procedures.
Yeah.
So those are their standardized forms, and that also helps in the teaching and uniformity, having that. And also the building the capacity in intersectoral, because you cannot work in watertight compartment. You have to work with the legal, the
multi-sectoral
that is also built up in this environment for the students.
So we know that Sri Lanka has a decentralization, especially we are talking about the NIHS system we have. I think one of the is a clearly demarcated population with certain coverage of population and accountable mechanisms. Even though we know that there are some lacking in that finance control and things are lacking, but most of the things are in the NIHS system. We have a good system we have, and the model, the NIHS model, totally depend on the training by this NIHS, especially for this NIHS, public health midwives and PHIs and this PHNS and things are there, and also they are contributing for this surveillance and community mobilization. So I think how this NIHS contributed for embedding this culture.
Yeah.
So already you have mentioned all working in training in one place is the thing. In addition to that, any other thing embedded this culture?
Yeah, this factor that the defining clear population area ownership in training. That also the students are divided and attached to the PHI students few students are attached to one PHI. And he is responsible for about 10,000 population. Similarly, midwife students are attached, few of them attached to a So, and the midwife population about average of about 3,000 population. So they see that this population demarcation which is in the norm for the whole country. So then also developing the epidemiological surveillance competence, going through in the population and see that
investigations,
mapping and all that, doing investigations, this thing. And also training for rapid outbreak response. That is also very important. They get, when there's an outbreak and they see of first-hand information, they are mobilized, in fact.
And that's what we see. No, we don't see much outbreaks, I think, nowadays. And I think, and also one more thing I can say for these indicators given for the public health infected midwives of, say, teenage pregnancy should be this level, or eligible couple registration should be this. These norms are created by NIHS, I think.
That's right, yes, and they are in line with the national guidelines. They prepare.
And later on, I think Family Health Bureau came into the scene, but
the guidelines are developed by them.
But initially, it's initiated by the NIHS, I think. So how do you think this is nowadays? This health system, the reliance, and across the political and economic transitions, there are different. It's now also we are going to face. I don't know whether it's a economical challenge again or things. Government also thinking about it in the recent Middle East crisis and things. So the system perspective, how has this NIHS functioned as a stabilizing institution anchor during these transitions? Especially we know in the 80s with the war we were able to do that, and later also recently the economic crisis and COVID-19 pandemic. So how this transition ensuring this community of training and supervision in the public health preparedness.
We saw that although there were disruptions, the training continued. Even during COVID, I visited the Vadua training facility, and they have done various things to brought the students to close by their found accommodation, and so they continued with the training during the disruptions also. That was one feature. Otherwise, if the national disruptions affect the training, then it will affect the whole system. Other is the institutional memory and the knowledge retention. Also plays an important role, and rapid adaptation during emergencies also. Mobilizing the students also in the operation.
What do you think about, you were in the Deputy Director General of Health Services and planning and things. The Ministry of Health and the government of Sri Lanka support, especially for budgetary allocations for functioning for this. Is there a separate budget line for NIHS? And
the NIHS has a separate budget line, but later it was brought under, earlier it was directly controlled by the ministry. And then when the Education, Training and Research Unit came, NIHS was brought under that. So when they were developing the ETNR unit, they were thinking of why can't we upgrade, make the director NIHS as to be the director. It happened really. Dr. Janisara, he was the director NIHS who took was the first second ETN director, DDG ETNR. So
what do you think? Earlier it was directly under the direct DGHS. Then
there was a little continued disruption to the relationships and the ministry and the thing, because the new unit it was developing, education, training and they are responsible for education, training and research. All
and not only for NIHS,
and they didn't have even staff. They had, only the DDG was there. So from the planning unit we had the director management training, we post were transferred to ETNR, and then director NIHS was one of the directors under the ETNR.
So is this change, this impacted in the functioning of these NIHS things?
Yes, to a certain extent. We anticipate it will improve. But otherwise, I can remember I was there during the transition period for 10 years at NIHS. The ministry hierarchy, even the DGHS frequently visits NIHS because it was directly under under the Dr. Balingam used to come and this thing. But later when the ETNR, when it came, the hierarchy didn't visit that place.
Because they have several other nursing schools and other places.
So many things. So NIHS, that this thing was lost to us.
We also be able to feel
we need to bring that back and see that.
So the mechanism, I think we need to. Still, we can feel that this NIHS those days.
Yes,
it's not there.
Yes, that's it. In that glamour, and this thing was not there.
So that's one of the message we want to see. I think that something need direct supervision.
Yeah.
From the ministry is very important. Yes, sir.